We now move forward to the next session. Our chairpersons for today's session are Dr. Adinath Rajguru, sir. He runs an IVF center at Akshay Hospital at Osmanabad. He has been the past president of IMA Darashiv Osmanabad and the past president of Osmanabad OBGY Society. He has been a faculty at various national and state level conferences, and he has been awarded with the Award of Excellence by the auspicious hands of Joint Secretary Health, Government of India on the occasion of International Women's Day at Delhi. We also have our next chairperson, Dr. Sujata Kulkarni Madam, who is the current Vice President of Solapur OBGY Society, and Dr. Sadhna Deshmukh Madam, who is consultant at Suyash Nursing Home and at Ashwini Sahakari Rugnalaya. Her areas of interest include sonography and high-risk obstetrics. I request Dr. Sadhna Madam to please start the session with introduction of our first speaker, Dr. Raju Sahetya, sir.
Hello. We welcome you, Dr. Raju. Actually, he's been introduced quite well since yesterday.
That's why I feel at home.
Yeah, we feel at home. He is currently at Pushpa Hospital, PD Hinduja Hospital, and Cloud9. He has many awards and honors to his credit. Everyone has seen him teaching the invasive procedures. He is trained in OB ultrasound at Mediscan Chennai and conferred to FIC MU by the College of Medical Ultrasound. He has trained many students, and now we have added to the list. He has more than 75. Yes. Yeah. He is dedicated for Women's Health Award, and he has also received Lifetime Achievement Award. So, on to you, sir.
Well, thank you. Thank you for the kind introduction. And I stand before you. I must compliment for the academic feast. And truly, this fetus as a patient, I think it has been programmed like an international event. This is how I feel when I stand before you. When I said academic feast means I learned so much today, since morning and even yesterday, that, I want to get you back to where we start. And we as obstetricians, as clinicians, this is what nuchal translucency. When nuchal translucency is done, and thereafter we start thinking as to how the fetus is going to be. So there are situations where there is increased nuchal translucency and yet there is a normal karyotype fetus. So what are the implications and management in such situation I am going to talk about? We all know what is nuchal translucency. Nuchal translucency is nothing but a sonographic measurement of fluid collection at the back of the fetal neck during the first trimester. Now, increased NT can be associated with chromosomal abnormality, structural abnormalities, and the genetic syndrome. But you have to keep in mind that in spite of this, many fetuses may be having a normal karyotype. So this is how the protocol goes. First, you should know that it is performed during the first trimester by an ultrasound. Second thing, when between 11 and 14 weeks. And what is the criteria? That the crown rump length should be between 45 and 84. And then proper positioning is the key. And Fetal Foundation has given those guidelines. It should be neutral position and it should be in mid-sagittal. Then what comes next is you have to measure this NT in millimeters, and the results are compared keeping the gestational age in mind. So this is what I was talking about, and we know that nuchal translucency varies with crown rump length, and you can see the graph chart over there. Normal roughly is when it is less than 3.5, but yet depending upon the gestational age. Real normal is between 1.2 to 2.5 millimeters is really considered normal, and this is what you see. Increase NT greater than 95th centile for crown rump length depending upon the CRL. The incidence of this happening is in 1 to 2% of all pregnancies. Risk of aneuploidy with increased NT is directly proportional to the value of nuchal translucency. That's what we keep on seeing, practicing, counseling, and you should know that less than 2 millimeters have a risk of less than 1%. As the millimeters of nuchal translucency increases, 3.4 millimeters have a risk of 7%, 3.5 to 4.4 millimeters have a risk of 20%, and 5.5 to 6.4 has risk of as high as 50%, and when it is more than 8.5 millimeters, the risk is 75%. So in the majority of the fetuses with trisomy 21, the nuchal translucency when seen is less than 4.5%. When it comes to trisomy 13 and 18, it is 4.5 to 8.4%, and in Turner syndrome, you will find it more than 8.5%. This is the coronal section of the skull. I spoke about the mid-sagittal neutral position, but in the coronal section also, you can measure this and suspect. So 50 to 70% of the fetuses with NT have a normal karyotype. We after this, we do invasive, we do chorionic villus sampling, we do amniocentesis. We are happy to see that 50 to 70% with increased NT have a normal karyotype. Chances of delivering a baby with no major abnormality with increased NT also is to be related to the thickness of this nuchal translucency, and 70% of the nuchal translucency, 3.5 to 4.5 millimeters, 50% are the affected one when the nuchal translucency is 4.5 to 5.4%, 30% for nuchal translucency of 5.5 to 6.4%, and 15% or more when it is 6.5 or more. Causes of increased nuchal translucency therefore should be known because the karyotype is normal. So you cannot blame it to trisomies. So you have to know the other causes, and you should remember that structural abnormalities, example the cardiac defect, omphalocele, diaphragmatic hernia, body stalk anomaly, and skeletal defects is in the first category, and the genetic syndrome like Noonan syndrome, Smith-Lemli-Optis syndrome, congenital adrenal hyperplasia, and fetal akinesia. Congenital infection has to be kept in mind when you get a normal karyotype, that there could be some infection what is causing this, and transient development of variation. Now infection and lymphatic goes hand in hand. So when there is infection, the lymphatic system is affected, and therefore there could be a transient development of abnormality and increase nuchal translucency. Normal variants, no pathological significance also you must keep in mind. In monochorionic pregnancy, monochorionic twin pregnancy, it can be predictive factor for twin-to-twin transfusion syndrome or selective fetal growth restriction. So what do you do next? You have to work up these patients. Non-invasive prenatal screening for common aneuploidies have to be done when you see this. Otherwise, the answer is going to be with invasive prenatal diagnosis, and that is chorionic villus sampling or amniocentesis in only those who are screened positive. You must keep in mind the maternal infection. Therefore, torch is indicated here. We have given up with doing torch as a routine for RPL or things like that, but in such situation, you may have to do torch. Fetal echocardiography to assess the congenital heart disease, because it is the heart disease and the backlog and the cardiac failure which can cause increase in nuchal translucency. Genetic testing for non-chromosomal condition is also important, and detailed fetal anomaly scan between 18 to 22 weeks and serial ultrasound examination. Genetic counseling is the key, because nowadays Dr. Google is going to tell them NT increase means you have all the problems on this earth. So you have to guide them what it means and what is to be done in such situation. Outcome and the prognosis matters a lot to all of us when we practice obstetrics. So many fetuses with increased NT and normal karyotype has a good outcome. You should not panic yourself nor make the patient worry about this. Isolated increased NT often resolves, has a good prognosis. So a good ultrasound follow-up is very important. You may see after a couple of weeks, when you do ultrasound, this nuchal translucency is going to reduce. Associated structural or genetic issues may affect outcome, may require specialized care, and that is what is fetal medicine all about. Increased risk of adverse outcome in such cases is when there is risk of leading to preterm birth, low birth weight, and intrauterine death. Long-term follow-up is recommended. So early detection and management are critical for optimizing results. And this is one algorithm. You could take a picture of this, how you should follow such cases. Nuchal translucency value above the 99th percentile, that is 3.5 millimeters. What you should do is a fetal karyotyping by CVS and detailed anatomy scan. We are very fortunate. Our machines have improved, our skills have improved, our knowledge has improved, and the hands behind the transducers have doing such lovely job that detailed anatomy scan at 11 to 13.6 weeks should be carried out. If the karyotype is normal, what would you do? A fetal echocardiography, because a cardiac defect, like I mentioned, leads to cardiac failure and the backlog and increase in nuchal translucency. Detailed scan between 20 and 22 weeks is very vital for the exclusion of diagnosis of major abnormalities and malformation. If persists at 14 to 16 weeks of pregnancy, becomes that there is also possibility that you will see is nuchal edema or nuchal thickness, what we call. So possibility of congenital infection or a genetic syndrome, 10% risk of evolution of hydrops, and perinatal death or the possibility of genetic syndrome has to be kept in mind. Risk of neural development delay is seen in 3 to 5% of these cases. So the management strategies is multidisciplinary approach involving maternal fetal medicine specialist, monitor for resolution of increased NT and detect late onset anomalies, pediatric cardiologist if cardiac defects are suspected, parental counseling to discuss findings, diagnostic options, potential outcomes and follow-up plans. Patients will be with so many questions. Like I said, there is Dr. Google waiting there who doesn't see that patient but generalize the answer. Therefore, you have to be a good counselor. Regular ultrasound to monitor the structural anomalies and growth. It is very important because these pregnancies can have a growth restriction also. Postnatal evaluation and genetic testing if anomalies persist. So takeaway today is detailed anatomy scan and echocardiography, serial ultrasound examination, genetic counseling and increased surveillance and monitoring. In conclusion, I would like to say that increased NT in normal fetal karyotype requires comprehensive evaluation to identify underlying causes. Early diagnosis and management are essential for optimizing outcome. Individualized management ensure better outcome for the fetus and family. Most cases with isolated increased NT have a favorable prognosis, and I must thank you for your attention in spite of pre-lunch and hypoglycemic state. Thank you very much. I love to come to Solapur. One is for the society you have, the Solapur OBGY, and my friend Milan is there, and he remembers me, and I like to come. And above all, I like to teach. Thank you very much.
Thank you, Dr. Raju. It was a wonderful take-home message. And especially, NT has become a stigma, like everyone gets panicky, and you have nicely elaborated the things. Thank you so much, sir.
Thank you
And
very much.
Yes, you should come very often now. Yes.
I'm there
Thank you.
and anytime.
Thank
Yeah.
you. Thank you so much.
Thank you. And I will come because my friend is going to become ISPAT president, then he's going to become a Foxy president, and more, and we all are going to support him in Mumbai and everywhere. I suppose you are the loved one. Thank you very much.
Thank you, Dr. Milin Shah sir and Dr. Monica and whole organizing team of Fetus as a Patient Conference to chair this session. We are having the speaker Dr. Ajit Patil. He is from Kolhapur. He is a chief consultant and director of Pristine Fetal Medicine Unit at Women's Hospital, Kolhapur. He is a best teacher. He is an ex-professor and HOD at D.Y. Patil Medical College, Kolhapur. He is trained in obstetric ultrasound at Mediscan, Chennai, conferred FICMU by the College of Medical Ultrasound in 2007, FMF certification in 2007, and started fetal medicine services in Kolhapur in 2005. He is having the first fetal medicine unit in Western Maharashtra. He has performed over 17,000 diagnostic and therapeutic fetal procedures. He is a trained PG students from MS OBGY, more than 75 research papers and presentations. He delivered about 400 lectures at various conferences and holds a Limca book of records in 2008. He has started the Down support group in association with the Down Federation of India.
I think we can stop here.
He is now presenting on the very important topic, dynamics of the assessment of cervical length. Sir, over to you.
Thank you so much, Dr. Rajguru, for those kind words, and thank you, Dr. Milin, for inviting me to Solapur and to share my work and experience with you people. Actually, as Dr. Vandana said before, I am an obstetrician, practicing obstetrician, and also specializing into fetal medicine. So I am doing that jugglery of one side obstetrics and one side fetal medicine. Probably it gives me little advantages because I can see the end result of what work we are doing. Of course, it's I think to the new generation of fetal medicine consultants that is coming in, it's my urge that you should not leave your legacy of practicing obstetrics, because our population problems are completely different as compared to the Western population. And interpolating research, the Western research into Indian population is very difficult. We need to understand our problems and try to design solutions for our people. And preterm birth is one of those, and there is no any pride in thinking or any, there is no any pride in looking at these numbers, because these numbers tell you that India is the capital of preterm births. Just a minute. Just give a minute till let some. No, ते माझा पॉइंटर हे झाला होता बंद पण झालं ऑन झालं. Yes. So India tops world in the incidence of preterm births and why this problem is there. If you look at the papers that are coming on prediction of prediction of preterm birth, cervical length is supposed to be one of the definitive markers of risk of preterm birth. And if you look at the number of papers that are coming, the first paper came somewhere in 1990, and now today we are in 2024. The incidence of preterm birth all over the world remains still the same. So there is something which we are missing, and we need to understand what these missing links are. Probably the reasons are two, that we do not have any effective screening modality for identifying women at risk of preterm birth, and we really do not have an effective solution for tackling these preterm births. And we know there are at least 6 interventions, 6 research-proved interventions which can reduce really the risk of preterm birth. But the issue is how do we identify those women who are at risk of developing preterm birth. And that's where entire medical world is debating about whom to screen, whether we should do a universal screening or whether we should do only a selective screening. What is an ideal gestation age to screen, whether it should be at 12th week or whether it should be at 20th week. What cutoff we should be using, that 2.5 centimeters or 1.5 centimeters, and what should be our intervention, whether it's a progesterone or Circla. So we are still debating upon the basic fundamental problems of preterm birth, and that's where probably I'll take you across the role of cervical length in identifying the patients at risk of developing preterm birth. Since you are all obstetricians, I'll just go through in learning how to measure a cervical length, and then we'll see some of the issues about the measurement of cervical length. We have seen yesterday one of the slides, the cervical length needs to be measured only transvaginally, and transvaginally. There is no role of measuring cervical length transabdominally because of the problems that are there with transabdominal route. Well, transvaginal route we know is most easiest when the landmarks are very easy to identify, the internal os is very easy to see. So how do? We put the probe into the posterior fornix, go inside first, so exert some pressure to identify the cervical canal, and then take that probe back again, release the probe completely so as to measure the cervical length. And look at the picture, cervical length, the internal os doesn't begin over here. This is some part of some part of the lower segment, while the cervix really begins over here. So that's your cervical length from internal os to external os. And remember not to press too much, because you take the probe back, and because if you are stretching the posterior fornix, the cervix will be opposed, both the walls of the cervix will get opposed, and will be erroneously measuring a closed cervix. So take the probe little back, and then you can identify this patient who has developed an open internal os. And also look at the structure of the internal os and how this internal os is placed. Most important is this presence of sludge, what is called as amniotic sludge, and this is a marker of subclinical chorioamnitis, and a definitive marker or definitive risk factor for women developing pregnancy loss, preterm birth. One nice article which is mentioned by USOG, and that's about the dynamic changes that the cervix shows. Like in Braxtonic contraction that we see in the uterus, the cervix will also have some amount of changes. And if you are lucky, you can keep the probe for 5 minutes, and if you see such cervix which is showing changes, it is getting shortened, the internal os opens up, again the cervix comes back to normal, again it opens up. That means this cervix is showing a dynamic changes in the cervix, and we measure the shortest cervical length and take it for our action. Elastography is coming new, and elastography just tries to measure the resistance of ultrasound waves, resistance for the ultrasound waves to travel through the tissue, and that's how we use, this is your B mode ultrasound, and that's when you put an elasto, the elasto will tell you how the tissue's consistency. In ultrasound words, we call it as the strain element. But for us to easily understand the ultrasound, by doing an elasto, we are trying to see what is the resistance that is the cervix providing for passage of the ultrasound waves. If this resistance or this wave color changes from red to blue, that means the cervix is becoming softer. For example, if you look at this cervix is predominantly in the mid zone, that means the cervical consistency is better. If the cervical consistency moves to this blue side, that means even though the cervix is looking normal, this cervix may be a softer cervix. But elasto has problems because elasto is highly equipment dependent. It has got an operator bias. It is a subjective interpretation of the color change, and there is there is lack of robust validation of applications of elastography for identifying cervical incompetency or cervical But there are some research areas which the elasto will probably come out because it has a potential to predict the softness early. Most importantly, if you put the patients on progesterone, and what if the color changes black to the reddish color, that means your intervention is working. So that's one area probably where research can come up. So they put the patients on progesterone, do an elasto, pre-progesterone elasto and post-treatment elasto, and see if there is any changes in the color that are happening. People have also come out with some markers. Unfortunately, one of the lab came in India with fibronectin, and again fibronectin went off. But this was a good protocol to see at which women have got a higher risk. Probably in this mid-zone category women, where the cervix is between 15 to 30 millimeters, if you do a fibronectin test and the fibronectin comes positive, probably the risk could have been higher. But in India, we don't have any access to fibronectin. So people also looked at some fetal parameters, and it's a very interesting paper. I have really no experience about this, but looking at the fetal breathing movements is again an important marker of an developing preterm birth risk. So what we come down back to, actually that's in cervical length, and we as an obstetricians are probably looking at a magic number. And that magic number is just 2.5 centimeters. In medicine or in obstetrics, I think in fetal medicine, for example, we are carried away with the numbers. Lateral ventricular measurement of 10 millimeters, cisterna magna of 10 millimeters, renal pelvis of 7 millimeters, in the same fashion, cervical length of 2.5 centimeters. So probably something magic happens around 2.5 centimeters. Anything which is 2.6 is normal, anything which is 2.4 is abnormal, and nature probably takes, and that's how we think that the things will happen, magic will happen around 2.5 centimeters. But in life, magic never happens. Remember, the cervix is a dynamic organ. The strength of the cervix will vary as its load will go on increasing. So it is not question of the structural length, it is the question of the dynamic strength of the cervix. And these two are completely different concepts. If you are trying to understand structural length of the cervix, you will be missing on those cervices which are softer. So what we really should understand, or what really we should break our heads on, is how do we understand the dynamic strength of the cervix and not the structural length of the cervix. So we did a small study. So we subjected 100 women for 100 women. These women did two scans, one at the 12th week, another scan at 20th week. And we just measured we correlated the shortening of the cervix between these two parameters, two gestational ages and their gestational age at delivery. There were 16 preterm births in this series. 16 were before 37 weeks of gestation and 10 births before 34 weeks of gestation. If you look at the shortening, if the cervix shortens by more than 8 millimeters, the predictive accuracy was almost 66%. So what is, in simple words, if the cervix shortens by more than 8 millimeters between these two readings, that is from 12th week to 20th week, the woman has 2/3 chance of delivering before 34 weeks of gestation. We tried to convert this into an Excel-based AI solution, and we fed all data, and now this AI equation identifies women into 3 categories, looking at the amount of cervix that is sort of falling short. So we have 3 categories: the low-risk patients, the intermediate-risk patients, and the high-risk patients. Obviously, those patients where the cervix is shortening. You look at this example, the first reading is 44 millimeters, and we are obstetricians who are carried away with that 2.5 centimeters. You will say this is normal. The patient goes to another scan center, comes back to you with a cervical length of 34 millimeters. Again, you are happy, the cervix is 3.4 centimeters. Again, you are carried away by that 2.5 centimeters figure. But look what has happened. This woman has shortened from 44 millimeters to 34 millimeters. What is happening to her risk of preterm birth? It is increased. So even if your patients come to your the scans from 2 different centers, always have a habit of looking at the cervical length. I usually tell my all my obstetrician students, to do their transvaginal scans on their own, because everybody has got a machine with its capacity of transvaginal scans. Probably today time has come, you're all 11 to 14 scan, and the anomaly scan patients will go back to a sonologist or a fetal medicine consultant. That's the need of the practice, because you can't spend that much time in your busy practice. But when the patients come back to your clinic with their reports in their hands, try to do a transvaginal scan on your own. Look at the cervix and see whether the cervix is shortening between these 2 measures, because if you can identify a woman which is shortening faster, you are doing a justice to that lady. So then what we did was we applied the same protocol in further practice. Another 100 women who underwent same scan, and look at the reductions. we could achieve a success rate of interventions, overall reduction of almost 56%. And most importantly, the group that is less than 34 weeks, a 80% reduction could be achieved in the incidence of preterm birth by simple interventions like simple interventions that will come ahead. So let us not accept these arbitrary methods. Let us not accept these fixed thresholds for cervical length in our clinical practice because they are arbitrary. You cannot play around the number. And for the same patient actually, either you will potentially overtreat or undertreat a woman who is around that threshold. So I think the practice of accepting this threshold should not be there. Rather, we should shift back to this two-step cervical length screening during the pregnancy. It should be applied universally and not to select women because all women have got a increased risk of preterm birth. And this is simple protocol actually. It is a proven efficacy. It's a very simple integration into your routine ultrasound practice. It is cost effective. It doesn't require any additional cost, any additional investigations, and obviously equity in care, which is very important. A woman walking in from a very rural area versus a woman who is from an affluent area should receive an equal quality care in our hands. And that's the duty. And therefore, such a universal application of two-step cervical screening probably will really decrease the incidence of preterm birth. I have made a small attempt of converting this whole into an online calculator, and you will find this calculator online. This is fetalcaresolutions.com. This is a free calculator actually, and those who are interested can go to this site, and you will have to download a file if you are using it on a laptop. If you are using on a mobile, you have to go to these 3 dots and download the add to home screen. So this is a very simple calculator, and it just shows you a small clip how it is was. So it will ask you some basic things like the email and MMC number, the medical council number, for a simple reason that we don't want patients to go in this app. And then you can feed, for example, here I am trying to feed a name, and a simple, as true with any software, this doesn't accept LMP, this goes by CRL because CRL is more accurate than the LMP for understanding gestational age. In the software, the calculator needs to understand the gestational age, so it will ask you the CRL, and once you feed in the CRL, the calculator will automatically assign a gestational age to that. And then you feed in the CRL the 2 intervals, the NT scan for this matter. It's very simple calculator actually, very simple. It was even your staff, your nursing staff, or your maybe probably the reception can also do this. And you enter the CRL of the second finding. Maybe even if the scans have been done by somebody else, you can still simply enter the findings and look at, for example, here this patient has shortened from 48 millimeters to 35 millimeters. Her risk has gone up to 80%. It also gives you certain recommendations and what you should do, and you just save it and go back. You can open the visit again, and you can see here you will get a small PDF like thing, some recommendations, and you need to enter. This is for research module. This is a research module, so that you will, after probably say accumulating 50 patients, 60 patients, you know what interventions you had done in your practice, and you save it, and you will generate a small PDF which you can get, which you can print it out and attach it to your antenatal card or antenatal file or your patient file, so that you can keep a track on this patient. It's a very simple tool, and those of you who are interested can definitely use. Of course, there are some limitations. DCA tool or this dynamic cervical assessment tool may appear to be an oversimplification of a complex problem like labor. With so much dynamics, we know there are multiple compounding factors which are responsible for preterm birth. But the DCA tool can work as an initial screening tool and can help clinicians to triage the risk probably. So what practice implementations we have? Definitely the two we know, less than 15 millimeters, we are going to put a stitch. Between 15 to 25, probably women will be offered progesterone. The dynamic cervical assessment tool probably will have a role in those women who have initial higher cervical length, which is more than 2.5 centimeters. And these patients, you put them into DCA tool so that you have two categories: low risk patients where you can observe. High risk patients probably, I have not gone into much into the interventions part, but the interventions will be highly individualized, and they could be simply like increasing monitoring, workups, progesterones, NSAID class steroids or magnesium sulfate for preparing the women for preterm birth. Very soon we are also working on an AI model where probably this AI will take care of the image understanding. So I am working with one very renowned ultrasound company, and they are working on understanding the ultrasound image. So you simply, the image goes to the machine, The machine will identify the internal os, external os, put a calipers and measure the cervical length, and then it will be combined with this dynamic cervical assessment tool, and probably in next few months we'll be launching this AI model. To summarize, I think it's only one about cervical length, and that's to measure, measure, and measure. Measure the cervical length correctly, measure it twice during the gestational age and note down the difference, and measure cervical length in all cases. If you look at the simple intervention that is possible to avoid preterm birth, that is a sensitized doctor. A sensitized doctor who understands what our society needs, what our population needs, is the best intervention that a woman can have for a fruitful journey into her pregnancy. Thank you so much for your kind hearing. I know it is conference quite running late, so yes.
What is the initial cervical length and assessment at 12 weeks, as you said, is 2.5 cm?
Yes, these are already high category patients. So they will not be subjected to this dynamic cervical assessment tool. They will require us individualized interventions because they are already labeled as high risk.
Because we will be doing a circulage, ultrasound indicated, history indicated,
Yes.
or repeatable, other factors.
So that's what actually is the ultrasound indicated cervical stitch or history indicated cervical stitch, definitely to be taken with a pinch of salt. If you look at your majority of the women who have delivered preterm in your wards, you will understand their cervical lengths were completely normal at their 11th week scan or at 20th scan. These women had a normal cervix. In spite of a normal cervix, they have delivered before 34 weeks of gestation. I still remember Madam Sardesai telling us in antenatal care, "Arey PV ke liska." So what she was trying to tell us was what is nothing but the same concept. That she was trying to tell us ki it is feel of the cervix which is important. And in ward, again you will see ki some women will have a cervix like this, small cervix, and still they will go to term. And some women will have a longer cervix and still they deliver. So it's not the structural length. That's the whole point of me telling you. It's not the structural length of the cervix. It is the dynamic strength of the cervix which is important, and that factor will indeed decide whether a woman will cross 34 weeks or not.
Very well said. You know, many a times we keep on alarming the patient about the short cervix, and then we have to induce such a patient. So the woman, she thinks that what were we talking about earlier? It's mostly, you know, we keep on telling, and then she doesn't go into labor also.
One question can I ask? Most of the times we find hourglass this on 20 weeks, 12 weeks, everything is normal, especially in primies. So do you recommend midway visit and reassessment of cervix at 16 to 18 weeks?
That's what. The cervix should be measured at 11 to 12, the 12 NT scan, and another cervical length at 20th week scan. It's important. If the patient is
in between. We find many patients at 20 weeks anomaly scan and they are hourglass. You know, everything is normal, no history, nothing. So is it recommended just to diagnose those not 1% patients?
Yeah, in your individual practice, you may squeeze in that 16th weeker scan. Okay. So when we designed the study, we wanted to reduce on the number of visits for the patients. Like so, we were looking at the two important gestational ages. That's the anti-scan, which is anti-scan and anomaly scan have become the universal standards. The 16th weeker scan or the 30th weeker scan have not yet become the standard of care. So in your individual care, you can definitely squeeze in a patient.
Thank you.
Thank you, sir.
Thank you, Dr. Ajit sir, for presenting nicely on the dynamics of the assessment of cervical length for prevention of preterm labor and preterm birth. Thank you, sir.
Our next speaker is Dr.Dnyandeo Chopade. Sir is MBBS, MS Anatomy, PhD, PGC Reproductive and Child Health. At present, Director, Genetic Health and Research Center, Nasik, Maharashtra. Sir is at present Professor, Department of Anatomy, SMBT Institute, Medical Sciences and Research Center, Director, Museum, Kolam, Nasik, National President, Down Syndrome Care Association, India, Director of Course Facilitator, Institute of Medical Genetics, Nasik, Honorary Secretary, Indian Society for Training and Development, Nasik, author of 4 books including Chromosomal Variations published by Scholars Press, Germany, advisor PCPNDT Committee, Government of Maharashtra, He has many research and awards to his credit. And sir is going to speak on a very different topic, that is intersection of fetal medicine and genetics. Over to you, sir.
Thank you so much, ma'am. It's great to be here. Thank you, Dr. Milin. I'm here just for you. Actually, it was too difficult for me to travel. I was traveling continuously and I could make it. Thank you so much. And I'm happy that I could make it. So the theme fetus as a patient is something which is incredibly significant. And I'm honored to actually share my insights into the subject which is at the intersection of fetal medicine and genetics. So over the next 20 minutes, I'll be talking about the pivotal role genetics plays in the overall period of the development of the fetus and how a medical geneticist makes a critical element of the fetal health. Okay. So to begin, just we need to get present. It is very critical to get present that fetus is individual with a very specific genetic makeup. And this impacts the health of the fetus, and this also impacts the decisions that we make throughout the pregnancy. Many advances are happening in medical genetics, in fetal medicine, and these advances have made us understand the fetal health very well, and it allows us to diagnose most of the diseases accurately now. It allows us to do prevention of some of the lethal genetic conditions. It also allows us, in certain cases, to offer the treatment even before the baby is born. And this all has to happen in the context of a multidisciplinary team. So, number of people, we have heard this a lot many times, so I'm not going to go in details of that. Let us visit this one small story. Edward, now 4, and he's doing amazingly well. What is special about Edward? In 2021, he was diagnosed at the age of 6 months with spinal muscular atrophy type 1. And then he was one of the first patients to undergo the gene therapy in UK, in the brand name of Zolgensma. His mother says he is at nursery, he can talk fluently, he is learning to walk, he sits unaided, eats everything. He is sweet, kind, and funny. He is literally the perfect kid. She is so happy, elated, saying this. She cries saying this. Why is this so? All normal children do this way. What would have happened had Edward not got the Zolgensma? So we know the normal course of spinal muscular atrophy type 1. We know it is one of the lethal genetic neuromuscular disorder which is characterized by the progressive muscle weakness caused by the degeneration of the motor neurons. Usually picked up before 6 months, you see the baby is floppy, having difficulty in breathing, swallowing, sitting. And in the course of, in the period of 2 years, usually there is death. And before death, the child is completely dependent on the hospital support, severely compromised life, dependent on the ventilative support. This is what the usual course is. With this treatment, earliest, if we can pick up the spinal muscular atrophy type 1 at the earliest and give this particular treatment which is existing now, what can happen is the result that we have seen in case of Edward. A tremendous shift in the lifestyle and life conditions. There is remarkable improvement in the muscle function, survival rates. Most of them, they don't need any kind of support, hospital support. And this is a single dose injection which delivers the functional copy of SMN1 gene directly into the motor neurons using the specially engineered virus. Now with this story, just get present to the scenario. Spinal muscular atrophy is defined as one of the rare disorders. With the estimates that we have, we don't have the accurate data. With the estimates we have in India, we expect around 1400 to 1700 babies born per year. Okay. One of the 7,000 rare disorders which are reported. You can just talk of the volume of all of them together and the possibilities in this world that we're talking about. So if you just look at the overall burden created by the genetic disorders at birth, you'll be amazed not just as a number, just put it in the form of what you can visualize. So I was thinking about like Solapur as a district, and I came to know Solapur is about around 1 million population. So every year about 1.6 million births are happening because of the rare genetic diseases in our country, 1.6 million. Plus 2 lakh more babies with chromosomal abnormalities. So we need minimum 2 Solapur districts to accommodate only the babies who are born with rare genetic disorders and chromosomal abnormalities. The estimates say right now in our country there are more than 64 million individuals with rare genetic conditions. And what does that mean? If you just translate that in reality, what part of the country it can occupy? You can just think of that. And this is only about those who are affected. Let me tell you, actually the affected, we call affected, are not affected because they don't know they have a problem. Who have a problem is the parents, the family members, the extended family members. So adding to this at least 4 people. And just now calculate the number of people who are in need of your support, our support. It makes a huge population. You can talk in terms of states. At least 4 Maharashtra states. We're talking of fetal medicine and genetics. So if you just look at the scope of fetal medicine and the extent, can be divided into 3 parts. Begins from the pre-conception period to postnatal period in 3 parts. Just take that example of Edward. Before he was conceived, parents were very happy, enjoying, romantic. She conceived, pregnancy was well, everything was good. Gynecologist obstetrician said everything is good, baby is delivered, they were happy. And within 2 months they could see that the baby is not making movement, and it was diagnosed as something called spinal muscular atrophy. Now that day or that year, there was a possibility of this treatment, they underwent that. There was a possibility of spending money doing that, they did that. Every year so many babies world over are born with spinal muscular atrophy and they don't have this access, isn't it? Now it's only 4 years since that treatment was given, and we really don't know how many injections that baby is going to require, what complications it will have, how long it will last. We really don't know that. But for now, his mother is happy, the family is happy with that kind of treatment. So what point we are going to make is, what are the key areas where there is a tremendous role of genetics and fetal medicine? Preconception, one of the very, very critical area which is mainly neglected. Pregnancy period is what we focus on mainly, and then the postnatal period. So in all these 3 areas, if we just create the strategies of intervening, doing some intervention, especially counseling, and identifying the people who are at risk, we might be able to reduce the burden to a great, great extent. Let us look at these 3 areas one by one. So in preconception period, look at this case scenario. A non-consanguineous couple, Rajesh and Priya, 32 years both, planning to start a family. Priya gives history of thalassemia major in her sister's daughter. This couple is worried about the risk of thalassemia major in her baby. They are planning a pregnancy. So in initial consultation, they were explained about what thalassemia major is, what is the pattern of inheritance, and the possibility of Priya being carrier because her sister is definitely the obligate carrier. So we need to test Priya, and at the same time, we also don't know about the status of her husband. So we need to test him also. We recommended the testing, and they underwent the testing. Carrier testing was done, and we found that both of them are carriers for thalassemia, beta thalassemia. And then they were explained about the possibility, 25% possibility of having a baby with thalassemia major. These are the different options offered. That is what we keep on offering, right? Natural pregnancy with prenatal diagnosis, ART, IVF with PGD, embryo transfer, donor gametes, or the adoption. What they chose was a natural conception, prenatal diagnosis. So CVS was performed. She got pregnant. CVS was performed 11 weeks. And we found that the baby he is being carrier for the thalassemia. They continued the pregnancy, and baby is born absolutely fine and normal. A very small, sweet scenario. Very commonly seen by you all, isn't it? 7,000 such conditions we are not aware of. We talk about thalassemia, sickle cell anemia, cystic fibrosis, sometimes the muscular dystrophies. 7,000 of them. We are not aware of that. And this is the same thing that happens. When we don't know, what happens is the baby is born. And then what do? We say there is nothing that can be done. So, as far as preconception period is concerned, it's a very critical period wherein we can pick up the couples who are at risk of having a baby with genetic abnormality. Now, which genetic abnormality? Most of them. Because we have the technology available, we have the sequencing and carrier testing available, we can pick most of them and identify if they are at risk of having a baby with genetic abnormality. So what does it involve? Preconception genetic intervention. It involves the counseling, it involves screening, it involves testing wherever it is required. So genetic health assessment of the couple, family history evaluation, pedigree charting, pedigree evaluation and risk calculation, genetic testing, screening or carrier testing or predictive testing, and then offering the various options, and they can make the informed decision based on that, and they can go ahead. What are the indications for? Indication, every couple who thinks of pregnancy is an indication. Every couple who thinks of pregnancy is an indication. But right now, that we must get present that we are now transcending or transitioning from medical genetics to genetic medicine. We must get present to that. Medical genetics is confined to the rare disorders, Mendelian pattern of inheritance, a very specific limited field. But now we are transitioning to genetic medicine, wherein we are bringing this into each and every specialty and each and every disease. That is what is happening right now. So there is no limit to, or there is no specific indication that way when we talk of the genetic medicine. But when we talk of medical genetics and particularly reproductive genetics, these are the indications. Family history of genetic disorders, consanguinity, high-risk ethnic groups, previous child with genetic abnormality, unexplained infertility or recurrent pregnancy losses, advanced maternal age, assisted reproductive technology, medical conditions with genetic predispositions. Preconception era. Prenatal. Look at this case scenario which is very common to each one of us. Anjali, 34 years old, pregnant woman. Because of her age, she was advised, the screening procedure was advised. She underwent the procedure and she was found to be at risk of having a child with Down syndrome. The risk of 1 in 100. So what do? Refer to a medical geneticist or counselor. The counselor explains about what that risk means, why we call it high risk, what is the possibility when the baby is born with Down syndrome, what is Down syndrome, what kind of life that person will have, what kind of support that baby will require from the family, all that explanation, right? And then offering the possibility of testing, definitive testing, which can be invasive procedures or the screening procedures with NIPT. In my experience over the last 10 years that I have been using NIPT in practice, when the baby comes positive with NIPT, it is Down syndrome. When the baby comes positive for Down syndrome with NIPT, it is Down syndrome. There is no choice, there is no other opinion about it. When it is negative, it is negative. That accurate NIPT is for Down syndrome. It is not accurate for other aneuploidies or the microdeletion syndromes, but for Down syndrome. So we can talk about converting this into, maybe it will require a lot many studies also, but we can talk about this as a definitive diagnosis for Down syndrome. We can skip the invasive procedures. So we can provide whatever is available, offer those procedures, and they can offer the procedures. In this case, she opted for amniocentesis was performed, karyotyping was performed, and the baby was found to be trisomy 21. After the test report, she was explained about again what Down syndrome means, what kind of life the baby will have, what are the complications, and what support the baby can require. What are the different support groups? Everything required for dealing with the child with Down syndrome was explained. And they were not ready to face the challenges associated with Down syndrome. They were explained about the possibility of termination of pregnancy because she was within the limits. Consent was taken and baby was terminated. This is the routine scenario in your practice. Post-MTP, so once this baby is delivered, terminated, next question is now what next? What is the risk? So that again counseling regarding the subsequent pregnancies, talking about the risk, how much risk the couple has and what are the different modalities, screening and definitive diagnostic modalities for dealing with that risk and preventing the birth of Down syndrome. So again the components of prenatal genetic intervention involve genetic counseling, genetic screening, genetic testing, going through all this whole process. Genetic health assessment of the couple, family history evaluation, pedigree charting, pedigree evaluation, risk calculation, Prenatal genetic testing, maybe carrier screening, biochemical screening, non-invasive testing or definitive testing through invasive procedures, and offering the various options like termination of pregnancy or continuation of pregnancy, or dealing with whatever the baby is born and then creating the surroundings for the welcoming the baby. So it is very, very important in prenatal care. This scenario illustrates the importance of early screening, accurate diagnosis, and compassionate counseling in guiding families through complex decisions during pregnancy. So I have a number of babies born and their parents took the decision to continue the pregnancy. It was identified during pregnancy. When explained well what it is to have a baby with Down syndrome, some of the parents are willing to continue the pregnancy also. And they are ready to face whatever challenges are there with the child with Down syndrome. So what are the indications of genetic interventions in prenatal scenario is maternal and paternal risk factors, which might be advanced maternal age, history of family history, carrier status, fetal ultrasound abnormality. So we have heard so many such examples so far. Abnormal prenatal screening results, double marker, triple marker, quadruple marker, the NIPT results, history of pregnancy related complications, teratogenic exposures, diagnostic information for some of the markers in assisted reproductive technology, and again the medical conditions which are associated with the genetic abnormalities like oligohydramnios, polyhydramnios. Coming to the third step, postnatal. Postnatal period is after birth of the baby around 8 weeks, right? So earliest identification of genetic abnormalities in this scenario, in this period, can allow us to treat some of the conditions which are really lethal. So this is a very critical period. Again, a case scenario. A consanguineous couple referred to for genetic consultation after the birth of their first child who was diagnosed with cystic fibrosis. Earlier baby having cystic fibrosis, this baby is having cystic fibrosis. Diagnosis was confirmed by the genetic testing wherein we could see the CFTR mutation. What concerns parents had was, is there a treatment and what is the treatment and what is the risk of recurrence in the subsequent pregnancy. So everything can be explained about what cystic fibrosis is, what are the health concerns, what's likely to happen, what systems are likely to get impacted, what is the quality of life. You can talk all about that with the available knowledge we have about the condition. And we can explain about what are the treatment modalities, conventional treatment modalities available. Now in this particular case, because the CFTR mutation was showing a specific gene mutation, there are a number of mutations which can cause CFTR. With a specific variant, there was a possibility of gene therapy, the gene product therapy, specific product, Evacaptor, which is very, very, you can say, very good in this treatment, and it can improve the quality of life of these babies with cystic fibrosis to a great extent. So what we're talking is a personalized treatment even in some of the cases. Slowly this is coming up. Though we know that most of the gene therapies happening today in the world are on trial level, slowly some of the gene products are coming in practice, and in coming few years you will find that these products are there on your table. So this way it is happening, and it is going to be personalized. That's why I'm talking about. It is not only medical genetics, it is transcending into genetic medicine, wherein we are prescribing a specific product to the specific individuals based on their variations. The child was referred to endocrinologist for comprehensive care, including the pancreatic enzyme replacement, respiratory therapy, and monitoring of the infections. And the family was informed about the availability of Evacaptor, which is costly because of the specific mutation G55-1D. In this case, the other family members were also the testing was recommended in them to just see if they are carriers, and if they are carriers, then we can go for the preventive measures in such family cases. We call this as a cascade testing. To avoid the birth of another baby in this case, they were explained about the nature, autosomal recessive nature of the condition with 25% risk, and they were offered all the preventive modalities, including the different options like natural pregnancy and prenatal diagnosis, IVF with PGD and embryo transfer, the donor gametes, and even the surrogacy, even the adoption. So they opted for PGD and IVF with PGD. They intervened the whole process. The embryo, which were normal, were selected and transferred, and the baby was born absolutely fine and normal. This is the third scenario. Now, at every step, we have thousands and thousands such scenarios and conditions. I'm just dealing with some of the very common that you and I are aware of. In conclusion, we can say postnatal genetic counseling and testing are indispensable in addressing the challenges posed by genetic disorders. That's for sure, postnatal. But prenatal and preconception, both scenarios are equally important from the genetic intervention point of view. This empowers the parents and families with knowledge, enhances preventive measures, and guides tailored management strategies for at least some of the conditions. For sure, at all the three possible levels, we can go for the definitive diagnosis and identification of the carriers. We can go for the clarification of the risks, do the risk assessment of occurrence and recurrence, and offer all the modalities which are available for dealing with the avoidance of the risk of recurrence as well as occurrence. We can guide the management in certain conditions and definitely offer the psychological support, which is the most important aspect of health. On this, in continuation of this, let me tell you something about, like, I've been taking lectures in a number of different platforms, and usually I talk about health as a concept which we neglect, and we talk mainly about the physical health, and we ignore about the mental and the emotional and the social health. Here, when it comes to genetic disorders, babies born with genetic disorders, they don't have any social or mental problem. They even are not aware that they have a problem. The whole family suffers. They are unhealthy in terms of when we define health as a specific term defined by WHO as a state of being well in physical, mental, and social domain. It's completely missing. So we are missing that segment around the babies with genetic abnormalities or individuals with genetic abnormalities. So this is my last slide. What's the impact? What could be the impact of genetic intervention at all the three possible levels: preconception, prenatal, and postnatal? Genetic counseling can make magic. If properly understood and delivered, it can make magic. It can transform people from anxiety, depression to something of hopeful situation. They can be empowered. Simple with communication, without doing any kind of intervention, because for most of the conditions we don't have it. Wherever it is possible to prevent the birth of the baby, we can do that. But when the baby is born with a genetic condition, in that situation, when you don't have anything to do, you definitely have something, which is compassion, which is your language, that can transform people in that space. That's one of the very powerful things that can happen in the world of healthcare. So genetic counseling, offering options, screening, testing, informed decision making, early interventions, preventive measures, personalized treatment, all that can shift the scenario, which otherwise is going to result into increasing morbidity and mortality. It will reduce the burden. It will reduce the impact by preventing the birth of abnormal babies, preventing the associated complications with the genetic conditions, optimizing the health outcomes, and reducing the anxiety, overall anxiety that you see around. With this, once again, I thank you so much for inviting me and giving me this opportunity for interacting. Thank you so much.
Thank you so much, sir. Actually, you have very nicely taken us through the all day-to-day problems which we come in OPD, like right from Down syndrome to thalassemia. Thank you so much, and thank you so much for coming from Nasik to give this lecture and enlightening us. Thank you.
Thank you so much. I would like to say one last statement. We are conducting programs, certificate course in genetic counseling and certificate course in medical genetics, online programs, 6 months and 1 year. Now, number of gynecologists are getting into that. There are pediatricians, anatomists, gynecologists, fetal medicine experts. And I must tell you, there is an amazing shift happening in the listening of people. See, it's not only about medical genetics or the testing. It's about being a human being in this world of healthcare, wherein we ourselves don't understand what health means. By asking a question, am I healthy? You can create the possibility of health by using whatever is available. And that is so touching. So thank you so much for this opportunity. Thank you. Museum Koham is a venture, unique venture in the world, wherein you can enter in discover yourself, and when you get out, you are someone different. Different in a sense, you really see the power of living, you see the life worth living, you create the purpose of living for your own self. It is completely scientific venture wherein I have created the models and concepts over 12 years, and it was placed in a place. Right now it is closed. After COVID, we closed that, and we are about to begin it on a very bigger platform in Nasik now. So that's the process happening. Yeah, thank you so much.
Thank you so much all the speakers and our chairpersons, Dr. Adinath Rajguru sir, Dr. Sadhna Deshmukh madam and Dr. Sujata Kulkarni madam. We would request our chairpersons to felicitate our speakers. We would like to call Dr. Milind Shah sir and Dr. Neeta Ghate madam to accompany them.
And Dr. Raju Sahetya, sir. Can I request Dr. Ajit Patil, sir, to please come? Dr.Dnyandeo Chopade, sir.
Raju was in Vietnam yesterday morning. He came to Mumbai yesterday midnight and then he traveled to Sholapur by LTT Visakhapatnam Express and he was about to complete the tour. I said, no, you'll have to cancel one day tour and come here because already your name has been declared. Immediately accepted. I'm very sure the Maldi is going to now scold me for that, but definitely will go once again to Vietnam because recently our group went to Vietnam from IMA, so same way we'll go again. Thank you very much, Raju, for coming.
I request Milind Shah,
Thank you
sir.
for letting me know that I could do this, that I could come one day earlier, and I would have missed all this. Just imagine, one day, last day in Vietnam goes in shopping. So I told my wife Malti, you just carry on with the shopping. I am going for academics. Thank you.
Yeah, I request Milind Shah, sir, and Ghate madam to felicitate our chairpersons, Dr. Rajguru, sir.
Chopade and Rajguru.
Chopade sir, मी announce केले sir, तुम्हाला द्यायचं बाकी.
Okay. Yes. Giving. हे त्यांचं आहे. त्यांचं आहे ना. इथं या सेंटरला या सेंटर. इथे या मध्ये. Even Dr. Chopade was supposed to travel somewhere, but I said, no, you cannot cancel. And he said, okay, I will come on Sunday. And he came. Thank you very much. Yeah, thank you. खरंच आहे मग. Yes. I had been to his center. He has a lot of books and museum. Yeah.
Dr. Ajit Patil, sir.
अजित पाटीलचं द्या. अजित पाटील तो पण हे घे मग ते त्याला पहिला परत एक्सचेंज करू. हां ते अंगठ्या ठेवतेच ना, अंगठ्या ठेवून देऊया आता. हां या काल दिलं त्याला ते. थँक्यू. येस superb it was. This talk was delivered in Dubai, isn't it? The same talk he said. Abu Dhabi, and then he said, it's a wonderful talk. I said, then please come down. And he agreed and came. Thank you very much. And I'm so happy that your daughter is also here. Good, thank you. Thanks a lot.
Our chairpersons, Dr. Sujata madam, Dr. Adinath sir, and Dr. Sadhna Deshmukh ma'am.
Yes. Adinath again a very close friend. I used to go to his hospital for endoscopy long back, 2002, 2003, yeah, 20 years back. Yes. Sujata. आता असं वाटतं तुला स्टिकर लावून देणार. Yes. एकाच दोन केलं. Yes, to save the time. आपण जेवूया आता 15 मिनिटं. मोनिका एक 10 मिनिटाचं गॅप